Good afternoon, everybody. Welcome to Office Hours, May of 2022. Um, I am recording the session as always, so we'll have that up on our HI website in the near future. And as always, any questions or chat questions you want, or you can unmute yourselves along the way. So I thought we'd get started here. So we're going to hit our usual policy and procedure slide. We'll touch on some children's program updates, COVID-19, quality notebook discussion. And then we're going to talk about our annual chart audit process that we're conducting as a health home, uh, update for Netsmart, restriction exception codes. And then we have the MAP health home tracking system segment end date reason code update. And then we're going to have a little discussion around Adirondack ACO HI Fidelis collaboration that's occurring. So a fairly full agenda today. But before we get into that, I want to welcome White House to the network. We mentioned this last month that they were on the verge of becoming an approved provider for HI Health Home, and they are on the very end steps of that right now. They're going through the process of getting their access to MAP and HCS platform. Once that's completed, they'll be ready to start taking referrals for children in our network. So wanted to congratulate them and welcome them to the network. Jason McLaughlin, the executive director of White House, and Tanya Vasic, who's our care management supervisor, operations manager, I believe is the title at White House. Welcome both of you to the network. So just wanted to acknowledge their presence.
Thank you, Travis, very much. We really appreciate being here.
Yes, we're happy you're here as well. There's a lot of children out there in need of services, so you're going to be a nice addition to help support that need.
Yes, thank you.
So with that being said, White House will fold into, they'll be the 24th organization in our network. As you can see here on our next slide, we're still working with St. Joseph Rehabilitation Center and People USA as they go through the steps of getting their MMISD numbers and getting to the point where we can do onboarding training for those organizations. So they're in the hopper still. So we're continuing to grow as a network, and I'm really excited about that. So thank you all for being a part of this. Policy and procedures. We have a number of policies right now going through review administratively. So in the next week to 2 weeks, you're going to start seeing them come out to the network. As promised in prior office hours, we will take time to go through those policies during office hours as well, on top of sending them out to the network so that folks have a chance to have dialogue as we're walking through those policy updates. So look to comprehensive assessment update, informed consent policy update, update to our disenrollment policy, health home qualifying conditions, referrals and assignments, our HCBS rights and choice policy, and then our palliative care bereavement services policy, which is a brand new policy actually for the Children's Health Home, which will be coming out shortly. And then as always, we have on our website the link to the policy and procedure page for all current policies that are active through the health home. So please take time to look at that if you have a reference or in need of a reference to check that out. But I did want to pause a moment to see if there's any questions on any existing policies that anyone might have. All right. Well, stay tuned. They're going to be coming. We apologize for the rapid fire, but we had a number that were coming due all at once. So here we are. It goes ebbs and flows, I guess. But here we go with the flow. So they'll be coming your way. Jessica, if you would go over children's updates.
Hello, can you hear me, Travis?
Yes.
Okay. I'm just worried because I have my WebEx PTSD about my volume.
Oh.
Yeah, so children's updates. Not much to update you guys on. I just wanted to see if there were any questions on the new 5201 that went live on May 1st. So as of May 1st, any new enrollment should be using the updated 5201. And anyone who is currently enrolled, you have 6 months from 5/1 to get their consents updated. Does anyone have any questions on the new consents? Okay, if you do, just email the health home and they will route that to me and then I can get you an answer. Just another wrap-up item. We had our year 2 HCBS audit a little less than a year ago. From that, we were placed on a corrective action plan for those items that received a score under 80%. Some of those details I went over last month at office hours, and part of that follow-up, I have completed a HCBS audit of all of our active HCBS waiver use. So I have reached out to all of our CMAs that actively have enrolled HCBS youth to schedule a follow-up to those reviews and to schedule a refresher training. So those have all been scheduled. All other of our CMAs that do not have actively enrolled HCBS youth, I will be reaching out to you to set up a waiver training. I did prioritize those that were currently serving that population, so keep your eye out for an email to schedule that. And I also will be reaching out to the supervisors of all of the CMAs. I did want to convene a supervisors group, not so much as a training, but kind of just to discuss the waiver process, workflow, and review the audit tool for HCBS, so that could be used internally as well when you are reviewing HCBS, and to go over the HCBS toolkit that has all of the tools and forms that would help you complete the process. And our year 3 of HCBS waiver audit is scheduled to begin July 29th. So there's more to come on that. Did anyone have any questions about HCBS in general, or any of the audits, trainings, or upcoming audit? Okay, well, if you do, please email us and we will get back to you.
Thank you, Jessica.
Yep.
Okay, so we just got, I was on a call last Friday. A few of us actually were on the call with the state, and it was DOH MCO subcommittee meeting. And our Department of Health Home Director Peg Elmer had made the comment that CMS had recently committed to the Department of Health a 60-day notice. I know in the past we had mentioned that they were going to try and give a window. That's what they were working towards. Well, they in fact gave verbal that they would give DOH a 60-day notice prior to the public health emergency ending, the federal public health emergency, that would allow time to ramp up to get back to business as usual. So with that being said, the current waiver was due to end in July, and that notification to end would have likely come out last week. And since CMS did not do that, Peggy had indicated that there's a good chance that that's going to be extended for another quarter. So we're looking at through September likely. Now, there hasn't been anything official yet, but I wanted to share that information with folks just so you know what's going on, given the fact that there hasn't been a hard and stop rule at this point. There's been a lot of talk and speculation. Well, that needle keeps moving due to the influx of cases and the rise of cases, not only nationally, but we're facing in New York State, in particular, North Country, in this area as well. So that is the latest on that front. So what does that mean? Well, that goes back to the reiteration that we've talked about a number of times over the last half a dozen months or so. DOH is delivering the same exact message as well. So I keep this slide in here just to keep that fresh for us. Even though we're going to get that 60-day ramp up to help prepare to get back to business as usual, quote unquote, there's some things we should be doing now to get ourselves in the best shape possible as organizations to prepare for that. So, encourage those face-to-face where it's appropriate and safe to do so, which is the biggest factor, of course, safety first. And just be aware that that verbal consent's going to go away once this federal emergency ends. So we can't rely on that as our quick go-to. It should be a last resort. And really, excited to know that the electronic signature is likely to remain after this public health emergency ends. So that's a positive that's coming through all of this. That should help moving forward with acquiring signatures. And any more questions around that, there's the link at the bottom here, just so folks have that as a reference to get the most up-to-date information through the Health and Human Services Public Health Declaration website. And then how's that resort to our Health and Plus population, the members that fall into that acuity level. Expectation is face-to-face is going to occur, especially once that federal health emergency goes away. So we should really be working towards that where possible and doing that risk assessment, which the link is provided again here for folks to have. OMH is holding hard line with this. Their word is basically the folks that fall into this high acuity level of service need to have these face-to-face interactions as part of the requirement due to the fact of the high need for Medicaid risk, recipient of service, that they need to have that interaction to get the supports that they should have. So that is where those two updates stand. I don't know if there's any questions, comments, thoughts with what we went over. The needle continues to move. I'm not sure when it's going to end. I was hopeful this federal emergency was going to end last quarter. Clearly, it's not. Okay. Well, if any questions come up, please reach out. As always, we'd be more than happy to talk through, brainstorm. Try and come up with some thoughts on how we can proceed if you're running into difficult situations or just don't quite know how to proceed on something. Quality notebook. So we've talked about this last couple months. Last office hours, we talked about May 9th due date coming up. That's come and gone at this point. We've had some organizations that were very responsive. So thank you very much for the folks that have been in those organizations. Some others have not been as responsive. So we're following up. The big message I want to relay here is that we want to work with folks if you run into difficulties with some of the components of the quality notebook. So please reach out to us if you're running into situations where you're having difficulty, getting some of these documents updated and compliance. We are meeting with organizations that are significantly out of compliance, in particular around the plan of care and the comprehensive assessments. And that's really coming down to the quality management program, which is something that, as we went through our redesignation, we're going to be working on to continue to enhance. And this quality notebook is a step in that direction. And, we are going to be following through a little more assertively than we have in the past, with this process. So again, we want it to be a partnership and it to turn into a proactive thing for folks to use as a tool versus a reactive. I mean, some folks right now, some organizations are faced with a myriad of challenges with staffing and lack of staffing, et cetera. So we're totally understanding of that, but we also, we want to work with you to come up with ways so that you can accomplish meeting these requirements because they are policy. And at the end of the day, we did very well in our redesignation audit. If certain charts were chosen, it may have been a different story. So we want to prevent that in the future from being an issue potentially at all. So that's part of why we have this process in place. Didn't know if anybody had any questions or anything they wanted to talk about around it. One thing I did just remember was last time there was some comments around the validity of the document of dates not potentially matching up to what the reality was. So we did go back and when I say we, it was predominantly Taylor Dawson did checks manually to match to make sure that these dates were in fact accurate. And in most instances they were. In instances where they weren't, we did follow up accordingly. So we definitely want to make sure we're getting you accurate information as we're producing these documents. Okay, well, thank you for your partnership on this. We appreciate it. It's only going to make us stronger as a network. And again, any questions, please reach out. The next thing we're doing, we had been doing this a while back, and then the pandemic really got going and slowed our chart audit process down. We're reinstituting that process. So we're basically selecting an organization just about each month. We're doing a random sample of charts. We're, as a health home administrative team, splitting up those charts. We're doing audits of those charts. And then what's happening is Taylor is compiling all that information. And then we'll be in touch with that particular organization once that information is pulled together. And then we'll have a meeting to talk about the audit results, but also an ability for like an open forum for discussion, Q&A, et cetera, just to make it so that it can be a discussion in general about anything that might be on your mind as an organization, or thoughts, or feedback, et cetera, that you'd like to give the health home. We're open to doing these in person if it's possible. We'd love to be able to do that. If not, then we'll do that virtually. But we'd like to go in person when we can, if everything is safe and appropriate to do so. So they are going to be starting to kick up. We did start the audits over the last 2 months here. So as that information is coming together, we'll have some outreach to the respective agencies. So that is our quality management stuff for now. There are some children's subprograms that have been updated in Netsmart in the subprogram dropdown. So we now have early intervention and high fidelity RAP as options. So just wanted to note that for folks. They are live and active in the system. Last month we mentioned we were working towards that. We are there now. And then there was a reminder that Jessica wanted to make sure we had folks for HCBS waiver youth have those programs assigned in the system as well. So just a reminder for that if folks haven't been able to do that yet. Jessica, do you have anything else around this particular slide that you wanted to note that I haven't?
Hi, everyone. Yes, I wanted to know a couple of things. With the high fidelity RAP, that subprogram is added in there for a very small population of children that are enrolled in health home and high fidelity RAP. So this won't be a common subprogram that you pick. This is something only for those CMAs that are designated to do the high fidelity RAP. And then I just wanted to make a comment on early intervention. We did add this in there. However, we don't have any early intervention approved providers in our network at this time. This was entered as a recommendation, so it is there if and when we do have these providers added. This actually came up on a call earlier this morning when I was meeting with an agency. When you see early intervention subprogram on here for children, that is a specific set of children who are under 3 who are receiving early intervention and health home care management as their care coordination piece. Kids who are under 3 cannot be enrolled in early intervention and health home and receive case management through both services. Targeted case management is part of early intervention, so health home would be a duplication of service. So a health home care management agency would have to be designated as an EI provider in order to provide health home care management and do the TCM work that an early intervention provider would already be doing to make sure that we're not double billing. So it is a very specific set of kids. So if you have any questions about the early intervention program, or if you're interested in becoming an early intervention provider as a care management agency, please let me know and I can follow up with you. And then as always, please make sure that you are adding the Children's Waiver HCBS subprogram to your records This allows us to pull reports on our sub-programs, just like we would do for our adult program.
Thank you, Jess, for that detail. Appreciate it. Anybody have questions around any of that? Okay. So we'll move on to restriction exception code. So I just wanted, DOH had put forth these updates the other day, and I wanted to make sure everybody at least was aware of it. So they revised Code 95, basically, checking to see if a person's OPWDD waiver service approved, are they able to get health home services? And that code remains a compatible code for health home. But there was a change where they took out the language around notes of what the care manager needed to do if there was an RE code 95 that showed. And that used to be where you would have to, ensure that that person wasn't receiving care management from OPWDD before you move further. And there was, you had to go into the system and check and do all these back checks on it and to get that confirmation. All that stuff's been removed. And I put the links here that DOH provided just so you can see the exact verbiage on it. But the code's been revised so that care managers do not have to do that follow-up to confirm that eligibility piece any longer. And then there was a new code added, code C2. And this is around folks who receive hospice services. Now that's a compatible service with health home now potentially. So what that's allowing is, CMAs to work with hospice providers to ensure care management services is not duplicative, that there's, delineation of care management between the two. So there is a potential to have that compatibility for health home as well. So that code has been added. Again, the links are provided so folks can see that the detail behind that. But I just wanted to make sure you're aware of those updates. Anybody have any questions or anything they wanted to mention around that? Okay, quiet group today. Usually we have more interaction. But it's also very nice out. I'm trying not to look out the window as I'm talking. So, MAP, so the Medicaid Analytics Performance Portal. We have an update on the crosswalk for the health home tracking system, segment end date reason codes category. So the links here for that. So that was something that came through the other day as well. Just want to make sure you had that information. So if you so choose, you can go check that out and see what those updates are. And then I'm going to Karen Ashline now. Karen, if you're out there, I was going to turn it over to you.
I am. Thank you, Travis. Can you hear me okay?
Yes.
Perfect. Thank you. Hi, everyone. Thanks for a few minutes this afternoon just to talk a little bit about some collaboration that we're planning to do. So some of you know the Adirondacks ACOs had an arrangement with Fidelis. We've had contracts in place since 2018. Our current contracts, we have two different contracts. One, a level 2, which offers both shared savings, but we're also responsible for shared loss. We have about 46,000 Medicaid members. We have a level 1 arrangement for our HARP population, about 1,300 members, where it's really shared savings only. This is the second year we've really focused on some shared savings and how we can best serve and support that HARP population. Things that we focus on are not much different than the things that you focus on in terms of health home and primary care in our hospitals. We look at chronic disease management. We're really trying to make sure folks get their preventive services. And then what are some of the follow-up opportunities for both ED visits and for both ED inpatient, which also covers mental health and substance use disorder. We're really, I would say, scored, and it's a little bit of a tough word, but in these value-based payment contracts, it's both about, looking at unnecessary utilization, but it's also making sure that you're getting high-quality marks. That really takes all of us together to try to focus on that, and so one of our opportunities is really to look at gaps in care that our members may have and working with our different partners to ensure that those gaps are closed. Ultimately, it falls to the primary care provider in the Fidelis world, but it really takes a number of members on the team to support members to get the things that they need. And sometimes it's just a reminder to say, hey, did you have your mammogram? Or, hey, do you need some help getting there? Do you need transportation? Can I help you make the appointment? Those are all the things that you folks all know well that you do through your health home programs. We focus on some preventable admissions, both inpatient readmissions and ED visits. And again, it's often around folks not having good access to care, or maybe they don't know necessarily how to access some care that they need. And a health home care manager can have a real strong role in that opportunity. We've recently worked with Fidelis to provide the ACO with a monthly list of any of the members who are attributed to a primary care provider in the ACO, and I can say that it's virtually all of the primary care providers in the North Country. There are really only a few that don't participate. So our catchment area is, Glens Falls south to the northern Canadian border, west into Malone, and down into Saranac Lake. This list of attributed members will identify from the Fidelis perspective who are health home eligible, and of those members who are health home eligible who are not enrolled. So this is an opportunity for us to work together, the ACO and the AHI health home lead team and you as downstream providers to ensure that members who are eligible are able to receive health home services. The relationship that AHI and the Adirondacks ACO have will allow us to share that information with AHI as the lead. We'll look at where the primary care provider is and how we might best share that information with that primary care group, but then we can make sure we're reaching out and engaging members. I understand, too, that sometimes cold calling members is a little difficult, but if we focus on the primary care end and be able to get those members better connected to health home, I think overall it's just a good opportunity, better supporting our members, better, able to provide the care in our region that's needed, and increasing the opportunities for health home services. Happy to take any questions. We've just started really looking at this, and we had an interim meeting with the health home lead and one of our data analysts on the ACO team, so we'll start being able to provide that information to AHI and work with you as downstream providers to best support those members. Thanks, everyone. Appreciate it. More to come on this, and we'll be in touch.
Thank you, Karen.
Welcome.
So definitely more information to come on this as it starts to unfold, but hopefully, Karen was able to just give you a basic 50,000-foot overview, and if you have any questions, and now's not the time, please reach out otherwise, and we can definitely connect you with myself and/or Karen, and we can talk further to help explain a little bit more about what this initiative might look like and what our hopes are for it to be. So thanks again, Karen.
Yeah, you're welcome. Thanks, Travis.
Anything anybody had today that they wanted to talk about that we haven't, or anything you want to go back to that we did speak about? Just wanted to give some time for folks if you had something you wanted to bring up.
Hi, Travis. This is Mary Baker.
Hey, Mary.
I've emailed about this before. So with the OMH specialty care management agencies, the HH Plus, the legacy providers had to do the 2022 goal setting plan and use the psyches data, that OMH that they provided. And as you're aware, when they were counting cases, so when we're doing the HML and we mark yes to HH plus, but no to minimum services met for that 6-month step down so that we get the higher rate, they were figured in the percentages. So it looked as though we were performing lower than we actually were. And when I had my meeting with OMH, they weren't aware of that. And what they asked me to do when I sent my report in is to deduct the people that were in step down. And then they were going to look into things further and have an answer before we did the May HML. So I didn't know if you had heard anything more about it. I was probably on a call for about an hour with them
We haven't
regarding
heard
that.
we haven't heard anything more, Mary, and I know your inquiries come up a few times, and we were given direction from the Department of Health. I don't know, Jessica, I think it was 2019, because we pulled up the old information from the email correspondence, and the direction was to answer no on that particular question if you were going into step down. So that was the guidance given. And we have that in writing from Department of Health. So I don't know where OMH is at this point with that discussion. We can look further into it though and see if we can help push for the answer. But it's not something that we just decided to answer on our own. It was thoroughly looked at in the past, and I think OMH has taken more of the driver's seat now with the Health Home Plus, obviously, over the last year and a half in particular, with the change for the special mental health provider. So that may be part of the challenge we're facing right now with getting a direct answer on this, because there's been a shift of gears on who's actually taking lead on it. But I can see if I can dig in a little bit further. Jessica, do you recall, was it 2019, I think is what we were able to get a hold of, that we got that information?
Yeah, I believe it was July of, I think it was 2018.
Was it
was when
18?
I have that. Yeah, because the new Health Home Plus model went live May of 2018, and I believe in July is when I received that guidance from DOH. So if Mary, if you want to loop me in on if you have any email exchange with who you've been in contact with from OMH, I'll be happy to forward them the guidance that I was given on how to create that step-down rate code for the former Health Home Plus members, because that's the only way to create that step-down rate code. Otherwise, you're going to have to where a Health Home Plus person goes straight from that high rate code right to that very low rate code. So that's the guidance we were given. And if you have anyone that I can send that to, because I have from the Department of Health, I can send that right over, and then they can have kind of a discussion with each other on how we can generate that medium rate code for those step down members.
Perfect. I'll give you the contacts, and I remember that guidance as well. And I also know that one time or a couple times when we have not answered the way that we were instructed, you're right, we get that the low rate as opposed to that step down rate. So, okay, I will send you the names, Jessica. Thank you.
Sounds like there's a
thanks.
2-lane highway that's not intersecting right now with the change of guard, and I think that's probably where the crux of it is at the moment, is OMH is taking the lead with especially mental health population at this point, and DOH is backing down on that. So
we're
hopefully
not actually surprised about that highway, are we? This is Lori. Sounds like the shipbuilders are back in business.
That's right. Thanks for bringing that up, Mary. I appreciate it. I know it's been an ongoing question, so I can't imagine how frustrating it's been.
No problem. I don't mind getting a bad grade or a low score, but when you add all those in, it's like, well, that's not the percentage.
Yeah.
So I have to explain every time. So thank you for your help. And I do remember the instruction and the direction that DOH gave. So I absolutely get it. And we know that we won't get the correct rate if we don't answer that way. So thank you so much.
Oh, absolutely. Anytime. Anything else anybody had for questions or comments or thoughts on anything?
Hi, Travis. It's Jessica Casey.
Hi, Jessica.
Just on the same topic of the Health Home Plus, working with OMH, we found that in our total Health Home Plus eligible population category, that they were adding our members in outreach that were Health Home Plus eligible into the equation. So we're working with Prabhu from OMH to kind of hopefully get some updated data, because obviously we can't bill the Health Home Plus rate for members in outreach. And we had some
Right.
months where our total Health Home Plus eligible population was significantly higher than others because we had used some of the reports available to us in Psyche. So luckily we were able to pinpoint that. But just to give others a heads up that if some of your numbers from month to month for your total population don't seem really high, it might be that they're capturing outreach patients in that category.
Thank you for bringing that point forward. One of the things we've been trying to do is come up with the concoction of the formula that they use when they're doing the identification for eligible folks and folks served and not served, and what reports they're pulling from outside of psyches, and they won't share that with us. So what we've tried to do as a health home is we've developed those Health Home Plus reports. We're trying to pull from sources that we think they're pulling from outside of psyches, and we're fairly close, but we're not spot on of where they're at. So I'm not quite sure what exact sources they're pulling from outside of psyches. And it just won't share with us. We've asked a couple times and it kind of gets glazed over.
I ended up pulling with some reports out of MAP and just looking at that new health home flagged category and seeing that we had a lot of members in outreach with those flags, and that's how I kind of piecemealed together that was the issue for us.
Yep, good. Well, thanks for sharing. Appreciate that. Anybody have anything else they wanted to bring up, talk about?
Hi, Travis. My name is Audrey. I am a care manager with United Helpers Care Coordination, and I just want to follow up and touch base on some of our members plus that are stepping down this coming month to back to the regular care coordination level. So when doing the HML for the step down rate code, you would just say no to the Health Home Plus services being met. Is that correct?
Correct. If they're no longer eligible for the service, then there would be no.
And that would just populate this step down rate of code.
That would well, if they were not eligible period any longer for the service, it would be an answer no, and then the rate you wouldn't have that enhanced rate any longer.
Okay.
So you would answer no to the health home eligible. You would say that they're no to the health home eligible now. Is that correct?
If they're not eligible for the service any longer, yes.
How does that cover the step down?
Well,
Right. So if you're, I'm sorry, if you're
go ahead,
trying
Jess.
to,
Go ahead.
if they are going from Health Home Plus eligible, so they've been enrolled for 12 months, receiving that Health Home Plus rate for 12 months, and then they no longer, have those X number of inpatient visits, or they're now housed, so they're no longer homeless, and you want to do the step down rate under current guidance in order to get that high risk, high need rate code, that medium rate code, you're going to answer yes to Health Home Plus, and then you're going to answer no to the core services met. And that will generate that step down rate code, which is in turn also causing issues now with the report that Mary has discovered. So I'm going to follow up on that. But for right now, in order to get that step down rate code, you have to answer yes, that they are Health Home Plus eligible, and no to core services met. If you answer no and no, you will receive that low rate code unless they meet one of the other criteria to continue to meet that medium rate code.
Right. So if the person's no longer eligible for a Health Home Plus period and they've gone through the step down, it's no and no, which is what I thought was the original question. So I apologize if I confused anybody.
No, that's okay.
I have a random question.
Yeah, we're good with random.
All right. So this is Lori Bishop from AMH. I'm curious if anybody is using, I know that in the guidance for health home peer services is a component you can use for care teams. Does anyone utilize peer services within their programs?
I believe Essex County Mental Health has peer service tied to their programs. I don't know if anyone's on the call from there.
Yeah, Travis, we did have a peer, but she's working for MHA, and MHA does have peers, and
Okay, so she
and that's
transitioned over.
so they
Okay,
use that. Yeah. Um,
thanks, Bob. Is anybody on from MHA?
Yeah, hey Travis, it's Marissa.
Hi, Marissa.
Hey.
Were you
So,
able to? Yeah, did you catch Lori's question?
yeah, sort of, but Lori, what were you wanting to know? Was it something in Netsmart about care teams or?
Well, I mean, I'm just thinking we have a position here that we've utilized some other funding for, but it sort of dawned on me that the peer services are in the guidance. I mean, I haven't dug it back out. I haven't read it in a long time, but I felt like it was in the guidance that is that you can utilize peer services in your billing structure as part of your care team. Is that
Yeah, so I think we have, you mean just like certified peers? I think we have about 8 certified peers on staff now, and they are, I think maybe 5 of them, we have them added to care teams within Netsmart. So I know they do go out. I think some of them are listed as outreach specialists. Is that I think a category for a staff in Netsmart? So I don't know how that pertains to a billable service, but I mean, I know they provide lots of other billable services at MHA, but I'm not sure for care coordination.
okay? Well,
So I
just
don't-
knowing that you utilize that, maybe as I'm kind of working through this myself a little more, if you don't mind if I reach out to you, Marissa.
Yeah, no, like right now, the Peer Academy is waiving all their fees still, I believe, for all of their trainings. So that was really helpful. I just completed mine a couple months ago. So yeah, and if your agency provides any HCBS services, like, I know I can't do both, but if it was somebody else, you could also provide billable HCBS services. If that was the case under the same agency, but yes, please reach out. That'd be great.
All right, thank
Hey,
you.
Lori.
Yeah.
Lori, this is Jessica. Are you talking about using peers as part of the care team for the Health Home Plus staffing model?
Well, for Health Home.
Oh, okay. Because under the Health Home Plus staffing model, if you wanted to use a team approach where you have one assigned care manager and then you use the team approach, your team can also be comprised of peer support. And then
Okay.
any service that they were to provide would count towards those 4 billable services for the month, as long as one of them was done face-to-face by the care manager and the care manager does the care plan.
Yeah. So we do use the team approach model. I do have care team support specialists on staff as well, but I was specific in the terminology of the peer and kind of how that works, because I have a position I'm thinking of creating. So I just was curious about that.
Well, thanks for throwing it out there, Lori. Now you got some network connections to talk through it, so that's cool.
Yeah. Otherwise, it was going to be you in 10 minutes, Travis.
Right. I wanted to been as thorough as Marissa and Jessica just were. So,
Mm.
all right.
Travis and/or Jessica, quick question about the children's world. So it's Paul Pulsifer from Families First, for those of you who don't recognize my voice.
Hi, Paul.
How are you?
Good.
With the cans in the children's world set to go to a year instead of 6 months, I'm just wondering if there's been any chatter with DOH about the ridiculousness of an acuity score.
Go ahead.
So the workload for
Jessica gets
acuity
excited.
kid
Paul.
versus a high acuity kid is exactly the same. Like minus the face-to-face visit. So I just wondered if there was any talk about a true like per person per month rate, and just doing away with acuity score altogether.
No. So they are hoping, it's not set in stone, but we are hoping that come August, the cans will move from an every 6-month assessment to a yearly assessment. And then following in line with that would be a yearly update to the plan of care, a yearly update to some of the other things that we do, that they would all fall in line with that 1-year mark rather than every 6 months. There has been zero discussion about doing away with the acuity score from the cans. I don't think we will see that. We have discussed the kind of ridiculousness between the medium and the high rates, because a medium use and a high use all receive the same set of services, but you get paid about half the amount of money. So that makes no sense.
Yeah, that's exactly it.
But yeah, the low acuity, the requirements are less for them. So that makes more sense. But yes, that medium and that high, it's the same service, but 50% of the pay. And we have discussed that, but no one has offered any solution to that. One of the things we also talked about is on the adult side, there is the opportunity where if you don't meet all of your face-to-face contacts with a certain population, you put that in and you can still receive some monies for your work. And that is not the same thing on the children's side. If you don't meet outside of COVID, if you don't meet your face-to-face contacts, then you can't bill at all. So
Right.
Those two policies don't align on either side. So that has been brought up, and I think we're more likely to see some movement there rather than doing away with acuity.
Okay.
I don't think that
I guess
is
I'm
gonna
just being
happen.
overly optimistic, but
I believe so, yeah.
it's just like there's, aside from the face-to-face visit, which is the easy part of the job, all of the other requirements are exactly the same. The difficult stuff, they still need a plan of care, they still need a comprehensive assessment, they still need a CANS, they still need a safety and crisis plan, like all of that stuff is 100% the same.
Yep, that is
All right,
correct.
just was curious, that's all. Thank you.
You're
Well,
welcome.
the state loves paperwork, so that will probably never change, but if you can get us more money, at least it'll feel better.
Good luck.
I don't know if we'll see more money. I think we might just see money that we maybe didn't see before that we should have always been entitled to.
Well, that's more money.
Yeah, it's just going to be reallocated,
Yeah.
shifted around. I don't know if it'd be
Yeah.
new, it'd be just reallocation. Yeah.
Talking about more money. So as we know, the budget passed without the 5.4 COLA for health home care managers, which was pretty ridiculous. But anyway, have you heard any update on the 5.4 for HH plus? Because I received an email from OMH saying that the 750 rate, there would be a 5.4 increase. So is it a 5.4 increase to the 750 rate or to care management agencies providing HH plus? We interpreted it was 5.4 COLA to the 750 rate. So I didn't know if you had heard anything on that.
Nothing definitive yet, Mary, and we're also part of the Health Home Coalition through New York State, and they're usually pretty good about feeding that information to the health homes. And I haven't seen anything come across yet that's solidified what way that's going to look or actually be when it's finalized. Very vague, I think. It's too much interpretation at this point. I wish I had a better answer for you, but I haven't seen anything. Jessica, have you seen anything different to clarify?
No, the only thing is just that one email and really no clarification around it at all.
Yeah. If you're hearing rumbling on the computer, I'm home in my basement today working, so they have next door construction going on. So I apologize if you start to hear the earth shake around you. So no, Mary, we can keep our ears open though and see if something comes up shortly. But I can also reach out to Lori Lamphere at the coalition and see if she's had anything for further update on that.
Okay, sounds good. Thanks.
Yep. Great. Anything else? Anything else anybody wanted to talk about? It's a great discussion. Thank you all. Well, if there's not anything else, thank you everybody for your time today, and all that you do as always. And please reach out if anything comes up along the way in your travels. We'll talk to you all soon. Take care.
Have a great day, everyone.
Thanks, guys.
Bye.